number 3 of molar pain. This is a 43-year-old male that presents to your clinic with pain in right side mandibular molars. This pain started about 4 months ago, but has now gradually worsened. Pain varies between mild to severe, so sometimes it's about 1 out of 10, 2 out of 10, and then it can go up to 10 out of 10 as well. It's dull, it's throbbing, it presents for hours, sometimes it lasts the whole day, and usually triggers either while patient is eating or just after non-eating. Patient can't open mouth really wide because of the pain in the area. The muscles hurt as well on that side, but teeth inside look perfectly fine. There are no caries, there are no structural changes, no abrasion, iteration. There's no sensitivity or pain on percussion. Radiograph shows, however, that there is a bone impacted third molar present in the area, and even on the left side as well. But right side is not communicating with the nerve or the tooth, or it's not even in the surrounding or proximity of anything. What do you think is the diagnosis? Your options are, is this an infection? Is this a cracked second molar? Or is this, maybe this is persistent idiopathic dential pain? Or is this masticatory myalgia, TMD?
I'm going to launch another poll now. And here it is. So I'm going to ask the participants again to select the option that they think is correct. I'm going to keep it open for a few seconds. And here are the results.
I'm really happy no one picked cracked secondary molar. Though I do think that was a decent option though. So yeah, so in terms of third molar infection, that's something that comes up almost always. Is this a third molar or is this something else? In this case though, I thought I was trying to be I didn't want to be in any controversy. If there's a molar that's there and that's not communicating with adjacent tooth, it's not communicating inside the oral cavity, patient doesn't have pain on palpation of that area, just like in this case, I don't think it is third molar infection. A lot of times I do see that third molar sometimes is protruding out, or there is a local infection in the area, and it can become very difficult to differentiate between the two. And then, at the end of the day, you do want that molar to be out. And if that's the decision of a surgeon to take it out or the dentist to take it out, they can go ahead and do it. However, in this case, I don't think that's the diagnosis. I don't think this is persistent idiopathic dentiolar pain because this looks or sounds like muscle pain. I would pick that over that any day. The reason for that is persistent idiopathic pain can be there, but it's more continuous. In this case, it triggers after eating or during mastication. It only lasts for hours or hours. So, which again is not the case with neuropathic pain disorders. Those tend to linger on continuously throughout the day. So yeah, this is masticatory myalgia, TMD, which is temporomandibular disorders. So masticatory myalgia or myofascial pain, this is a condition that is part of the realm of TMD, pain of muscle origin that is affected by jaw movement function or parafunctional movements, much more prevalent in females than males and usually presents between 20 to 50 years of age. The clinical features of these particular conditions is that patient usually has pain that aggravates its function. So it, by definition, either it gets worse while you're eating or just after you're done masticating. Pain is dull, it's throbbing, it's sometimes vague and deep. Very rarely it's sharp. And then there's limited mouth opening, which is not because of function. So you can push them and it causes them to have pain, but you can actively open them wide. But passively, they do have limited mouth opening. A lot of times they'll complain of headaches and neck pain. And neck pain is because as masticatory muscles get involved, it does cause pain to travel towards temporal area, which results in a headache, as well as towards the back of the neck in the posterior cervical area, causing neck pain as well. And they have something what we call these trigger points or referred pain, which is basically these taut bands or taut areas within the muscle fibers that when are stimulated result in a characteristic referral of pain. So for example, if you look on the left side of your screen, you see these trigger points for, on the top is for the lateral pterygoid area, on the bottom left is for anterior digastric that results in referral of pain towards anterior mandibular teeth. And then masseter muscle results in referral of pain towards posterior teeth. Temporalis results in referral of pain towards maxillary teeth. And this is something that's common in all muscle types, but even in head and neck muscles, sternocleidomastoid, sternal, as well as the clavicoid branch of the muscle, they have a very different referral patterns. And then trapezius can cause pain towards the head and neck area, head area, or towards the temporal area as well. And then sometimes there is muscle tightness or this feeling that you have this continuous burden or swelling in the area, though physically there is nothing, but it's just a sensation that patient do feel. Management of these conditions is actually multimodal. There's no one particular therapy that has more benefit than the other. Primarily, if you start, the non-invasive or least invasive ones are physical therapy, such as ultrasound, laser therapy, electrostimulation, exercises, jaw stretching exercises, thermal compressions. There's no particular preference, cold over warm. I usually tell patients to try both and see whichever works for them. And then in terms of medications, you have analgesics and muscle relaxants. These are primarily, analgesics include non-steroidals of paracetamol, and non-steroidals you have nimesulide, celecoxib, naproxen. It's not that they are more effective than others, it's just that I think they're easier to take because you only take them twice a day. In terms of paracetamol, you can either have that alone or you can have them with some sort of other agents such as paracetamol with caffeine, or here we have a lot of people using paracetamol with orphanadrine. That works well as well. And then in terms of muscle relaxants, you can use cyclobenzapine, quizanidine. Those that are living outside of Pakistan, they can use methocarbamol or metaxalone. Metaxalone is something that I find really helpful. I used to use that a lot in Northern America, but they are not here in Pakistan. Here you have cyclobenzapine and quizanidine available. And then tricyclic antidepressants, I know we use them for neuropathic pain as well, but they also have muscle relaxant properties. And again, at a low dose, they work really well, and they are available here in local population as well. And then appliances. So you have different types and designs. No one particular design is superior than the other. You have these full coverage ones. They are available in both hard and soft form. I don't use soft that much because there is some evidence that it can cause more activity of masseter muscles or temporalis muscles. Plus, I think they don't fit that snugly as hard do. And with hard, you can always get good contact all around the teeth, whereas in soft, you usually don't. And then you have these partial coverage anterior bite planes and posterior bite planes. They are not superior than the full coverage ones in terms of masticatory myalgia, in my opinion, whatever I have read, but they do cause more bite changes. So that's not my first line modality that I would go on. And then you can also sometimes use behavioral approaches. I use these a lot for my patient who I feel that has a lot of stress component in their muscle pains and aches. These are the patients that, for example, will tell me that there's one particular activity when they do that, or for example, when they're driving, it causes them to have excessive amount of pain afterwards, or is that certain activity or certain lifestyle that they've done or developed, maybe it's related to their education, that causes them to have a lot of stress buildup and that causes them to have pain. I have referred them to psychologists, and here we have excellent group of psychologists that work again at Shaukat Khanum and outside of Shaukat Khanum that take really good care of patients, and I found pretty helpful outcomes out of it. And then you have injections as well. There are two main types. One, we have trigger point injections, which is basically done on the area with this maximum tenderness. So you sort of follow the pain kind of a process. This also helps to answer sometimes that if you're confused that whether this is whether it is actually emanating from muscles itself. In those cases, you can use trigger points to help localize. And sometimes if someone does have a trigger point, by just injecting a couple of few ml, not even few, but less than 1 ml of local anesthetic in the area, it does help to reduce the pain as well as break pain cycle and help with the diagnosis as well. In terms of Botox, there are multiple different techniques of doing it. You can use a test board pattern, which is you sort of break down the dosage and spread it across different areas. There's a reverse pyramid for masseter muscle, but no technique is superior than the other. So I have been doing it on 2 spots only. So I'll inject in temporalis and in masseter. We showed that in about 150 or 150 odd patients that this technique works really well. If it does, usually you have to repeat these after 3 months. And then sometimes you can spread it out. There are papers on it that they have done so by spreading it out. Then again, there is no one technique that is superior though than the other.